to Founder Fridays, presented by Crescent Foundation. I'm Kyle, joined with a very special guest, Dr. Farzana Sayani, who is the director of the Sickle Cell Program at the Hospital University of Pennsylvania, or HUP, as we'll say, moving forward. Dr. Sayani, welcome.
Thank you very much.
Thank you so much for joining us today. Today is September 1st. It is the beginning of Sickle Cell Awareness Month. It's a very special day and kind of hectic day as well within the sickle cell ecosystem, but specifically here at Crescent Foundation. We are happy to launch our website and also our virtual campaign, Strive for 100,000. We know that there are approximately 100,000 people living with sickle cell disease. So we want to educate 100,000 people on what the disease is, and also raise $1 for every person living with the disease. So that's $100,000. And today we are having a conversation in terms of patient-provider perspectives, and I thought that it would be great to have you on. One, because you're not my provider. I think that's really important for us to mention. Not anything personal. It's just how I'm being served at another hospital. Being served at Pennsylvania Hospital here in Philadelphia. But no conflicts of interest, which is great. So what I would love for us to talk about moving forward is first my journey in terms of sickle cell disease, and actually, I don't know if you know this, Dr. Sayani, but it starts at HUP. I was born at HUP.
Oh, cool.
Yeah, I was born at HUP in 1989. I was fortunate enough to be born there because other hospitals weren't implementing the new policy that was just mandated in terms of newborn screening for sickle cell disease. And, fortunately, my mom went there, although she was advised by some of her family members to go elsewhere because that's where other family members had given birth at other hospitals, and they told her to go to a different hospital. But she was like, you know what, I'm going to go to HUP. And luckily she did, because as she likes to say, I hit the ground running. I was diagnosed at 3 weeks, and at 3 months, I had my very first major complication in terms of my spleen filling up with blood. So I had to get a splenic sequestration. And who knows what would have happened if I wasn't diagnosed at 3 weeks. We don't even have to speculate, Unfortunately, I was born there. So and since then, I've had various complications due to this disease, and have been able to find just ways and methods to keep myself healthy as possible, to stay out of the hospital. And now I'm happy to serve as Crescent Foundation's co-founder and CEO to really just ensure those who are living with sickle cell disease, their lifespan, and advocate on their behalf. I was wondering if you could tell us a little bit about your journey in terms of being a practitioner and how you actually ended up at HUP.
Yeah, thank you. Thank you for sharing your very personal journey. I think I didn't know about your connection with HUP. Yeah, really neat. Well, for myself, I have been interested in medicine for a long time, interested in the science, I think right from a young age, I kind of knew I wanted to do something for people. Many people don't know this, not a lot of people don't know this, but I spent the first 17 years of my life growing up in Africa, and then moved to Canada when I was in grade 11, and then did a lot of my high school, university, medical school training in Canada, and only came here I've only been in the US since about 2012. And I was always drawn to hematology. I think through sort of first got started by, working on research and how red blood cells were developed. And I had a really good mentor. And I kind of knew that I liked the biology of it. And as I did more and more training through my training years, there's all, in hematology, you get drawn between either you do the cancer stuff or you do the non-cancer stuff. And I think because of my background being part Indian, part Chinese, having grown up in Africa, I think all of those different cultures made me a more diverse person. And I realized that when it came to learning hematology, I was drawn towards the sickle cell. I was drawn towards thalassemia. And it was actually the patients who I felt um, I connected with. And, um, you know, thalassemia, sickle cell disease primarily affect people with ancestries from around the equator. So there is sickle cell um, in the US, primarily the African American population. But in Canada, where I did most of my training, is primarily considered an immigrant population. Again, a marginalized populations. And I just felt that I could connect and I could hopefully help and do better for them. They were usually marginalized in terms of access to care, and the same thing applied to sickle cell. And I also find it just really interesting as a science and as a disease. I felt that I just feel like there isn't enough done. And as an adult doctor, I think overall, in terms of medicine, you have to really enjoy what you're doing, but also enjoy the patient interactions.
Mm.
The patient interactions and feel like you're really helping somebody. And for me, the thalassemia, sickle cell, caring for individuals who needed their voices to be heard, who didn't have cancer, but clearly had diseases that they were born with that clearly impacted their life. I felt like I could help them. And I think that that's sort of led me to sickle cell. And then I ended up here at HUP, and more so initially because of my husband getting a job here. And it's been challenging, but more lately, a more and more rewarding experience, both personally as a family, and also taking care of some amazing patients. So yeah, that is my story, really. Kind of
That's
long, but that's kind of how I ended up here. And sometimes you just got to go with what life throws you. And honestly, I'd never ever thought of coming to the working in the States. And lo and behold, we're here and we're having a good time.
no, for sure. Here you are, and we're happy that you're here. We're happy that you're having a good time. I think you just hit on some key points, right? Just really enjoying your work, enjoying the community, enjoying, just really bringing light to marginalized diseases. Uh, you threw some words out there too that maybe people may not be familiar with in terms of like thalassemia and sickle cell versus what are the differences in terms of that. But I was wondering if you could also shed light on just what actually sickle cell disease is, and how it really impacts those who are living with the disease.
I think that, yeah, so I can give you a little bit of a biology lesson. This is sort of,
All right, let's do it. Yeah, let's do it.
uh, so we're going to go a few steps back, okay? So in our blood, we have red blood cells, and red blood cells carry oxygen to tissues, provide oxygen. And in these little red blood cells, there is a protein called hemoglobin. And hemoglobin is actually what binds to the oxygen, and then the red cells deliver it to the organs and tissues. And that hemoglobin is really important, and it's encoded by our genetic material, our DNA. Um, this hemoglobin we think of it as being made up of two alpha components that are very similar and two beta components that are very similar. And normally you need two alpha proteins, two beta proteins, they come together and they effectively bind oxygen. They cause the red blood cell, they allow the red blood cell to be nice and flat like a disc, which can squeeze through the different small blood vessels in the organs and tissues and deliver oxygen. So what happens in sickle cell? What is sickle cell? So sickle cell is actually an inherited genetic disorder where there is an abnormality or a mutation in that DNA, that coding that codes for one of those beta proteins. Okay. Um, and what happens is when you have this abnormality in the programming, this protein, the beta globin proteins that are made are abnormal. And specifically in sickle cell, what it does is it, you know, that nice red blood cell that was nice and round and could squeeze through blood vessels. Now, um, with this abnormal sickle hemoglobin, those red blood cells become very rigid. So they can't squeeze through those blood vessels and they get stuck. And so now the tissues are not getting enough oxygen. Individuals can have pain and can develop problems, which we can talk about. Now, when we think of our hair color, our eye color, our skin color, the shape of our nose, it is derived, uh, we get a program from our DNA. We get half of our DNA from our mother, half of our DNA from our father. And so this normal hemoglobin, we'll say, you know, is AA. So AA is normal. Now, let's say an individual has one normal A, but that other one has a mutation in it, that abnormality that caused that sickle hemoglobin to form. So one is abnormal and one is normal. And so we can say that that abnormal one is S. So we've got one normal A and one normal S, and we call that sickle cell trait. So generally about, you know, about 10% of the African American population has sickle cell trait, and it's not a disease. It generally doesn't cause any problems. We see the sickle cell mutation common in many parts of the world. So it's primarily in the African continent. So people of African ancestry, the Mediterranean, there's a little bit in the Middle East, and then also on the Indian subcontinent as well in certain tribes. But then because of immigration, because of history, we now see it all over the world. We see it in North America and South America. Now that sickle cell trait was one of the really interesting parts of it is that it's protective in that people get less malaria, less severe malaria. And so that sickle cell, that abnormal sickle cell gene is allowed to propagate over generations. So now, let's say you're in a population and you've got two individuals who've got sickle cell trait. They're healthy, they don't have any problems, and they come together and they have a child. There's a 25% chance that they may have a child who has two abnormal S's. So there is no normal. Those globin chains are now both abnormal. So we say that they have hemoglobin SS, and that's sickle cell anemia, sickle cell disease. Now they don't have the protective effects of that normal hemoglobin. So now these red blood cells, remember I was telling you about those little cells that get really stiff? That really, really happens in individuals who are SS because they have no normal. So now these blood vessels start causing problems. So very similar to what you were talking about, you know, right when you're born, you had the splenic sequestration where the blood just kind of went into the spleen and those cells just caused a blockage, kind of like plumbing. They just caused a blockage. All the cells got stuck in there. And so right from a very young age, infants, young kids can have problems from pain, bones, organs not getting enough oxygen causes a lot of pain. They're also at risk of infection because their spleen doesn't work as well. And then moving along into adulthood as well, they have through the course of from kids to adults, we start having complications where there's no blood flow. So complications of the eyes, stroke risk, lung problems, kidney problems, leg ulcers, bone problems. So there are a whole constellation. So sickle cell disease is an inherited disease. Individuals are born with it. And unfortunately, it's a lifelong disease. Um, Different people are different. Some people have more a very mild disease, and it doesn't affect them very much, whereas other individuals have a much more severe course and have multiple organs that might be affected, have more pain. Um, and really, that's where I think, as a hematologist, as somebody who has an interest in sickle cell, that is where a lot of work is needed. I think, over the years, the pediatricians have done a great job. In the past, um, young kids were succumbing to infections, they were succumbing to stroke and many other complications. But over the years, with new advances in care, we see that the young kids are growing up. They are surviving childhood. They're becoming young adults and moving into adulthood. And as an adult provider, I must say that there is a lot that needs to be done for the adult patients now. The pediatricians have done amazing work, but how do we how do we enable and allow the young adults to continue living healthy lives and lives with that are good quality and long lives? So yeah, that's a little bit about sickle cell. And there are different forms. I think I forgot to mention hemoglobin SC is another form. So some individuals may have SC, S beta 0. All of these cause those red blood cells to kind of form a sickle shape. And then you get breakdown of cells and they get stuck in different organs. So you could kind of think of a friend had told me, sickle cell is a disease of where the blood flows. So wherever the blood flows, all of a sudden now you have blockages and the blood can't flow well, you're going to get a problem there. And our role is to figure out where the problems are and trying to prevent things from getting worse or even bad things from developing. Yeah.
You hit on so many wonderful, wonderful points throughout that biology lesson we just had. One thing, there's a hope that I have. I call it this restaurant theory. So let's say you and I were like walking into a restaurant and we surveyed, there were 10 people in the restaurant. We surveyed 10 people and we asked them, do you know what diabetes is? Chances are all 10 people would say, yes, I know what diabetes is. Let's say we asked those same 10 people, do you know the different types of diabetes? Chances are we'll be generous. 9 out of those 10 people will say, yes, there's type 1 diabetes, there's type 2 diabetes. And then we asked those same 9 people, all right, can you tell me what the difference between type 1 and type 2 diabetes is? And even if we get 8 or 7 out of those 9 who are able to say, yes, this is how type 1 diabetes affects people, and this is how type 2 diabetes affects people. Type 1 is usually seen, and you can correct me if I'm wrong, Dr. Sayani, I might need some help. You're the physician here, but type 1, if I'm correct, it affects children mostly, right? So, and type 2 diabetes is seen more in adults, usually those who have issues in I'm not sure what the actual medical term is. This is where I'm going to ask for your help, but is that,
Yeah, like metabolic syndrome,
that's the
to do with being overweight and not exercising, etc.
So we walk into that same restaurant, we ask people, do you know what sickle cell disease is? 10 people says, yes, 100%. Do you know the different types of sickle cell? I would love for here in the US for people to say, I know the 4 most common types of sickle cell disease. I know that there is SS, SC, S beta plus, and S beta 0, right? Or am I S beta 0?
Yeah.
Perfect. So, and then break it down and say how it affects those living with those different types. Um, I'm still learning. This is a learning process for me as well. So that's why I'm encouraging everyone else to, this isn't just education for everyone who's tuning in. This is education for myself, for the entire sickle cell community as well, because chances are, if you're living with this disease, you probably only know how it directly impacts your life, right? So meaning I have SS. I know how SS impacts me, what complications I've had, what common complications are seen within SS. But we should also know the other common types too. So one other thing you said too, which was just is how I really feel, is those who are in pediatric care, they they're okay. There's a safety net around them in terms of like how to treat sickle cell patients who are kids, and becoming young adults, and to get them into their adulthood. Unfortunately, it feels as though the healthcare system only tried to get us into our adulthood, right? It really didn't account for what our care would look like when we were adults. And I think it's unfortunate. And also knowing that there wasn't much there, a lot of people weren't living into adulthood, so there was a lot of unknowns. People that maybe didn't know how to impact. So this is me giving some kindness and grace to the healthcare system, just a little bit, not too much. I'm not too much though, but yeah, we just weren't accounted for as what we would look like as adults, and what our care really needed. So with that being said, why is it important for an adult living with sickle cell disease to not only have a primary care provider, but a hematologist? What is it? Why is it so important for us to have a hematologist following our care?
Yeah, I think that's a very good question. I think in pediatric centers, we've had in the Philadelphia area, for example, we've had excellent pediatric care in comprehensive centers where you have an experienced hematologist who has sickle cell experience, an experienced group of nurses, social workers, and their main focus is the sickle cell patient. That's what they do best. Any services, any education that is provided is all around sickle cell. And I think having an adult hematologist is important because as hematologists, we have specific training in blood disorders. And now they are hematologists who, many hematology programs, they're trained in both cancer and non-cancer disorders of the blood. And so even though they may do cancer, they still have experience and exposure. There is a big push for education and training of hematologists that's coming through the American Society of Hematology. So again, there's organized education of hematologists in sickle cell. So by having an adult hematologist, you're getting somebody who knows details about sickle cell, but also the fact that they're an adult doctor. As we become adults, there are adult problems that can happen because really at the end of the day, an individual with sickle cell can still get other medical problems. The physiology of the kidney, the physiology of the liver, all of those different, and other organs change as we become adults. And I think having an adult provider, the effects of the heart and how the heart changes. We talk about fertility, birth control, family planning. Those are all very adult topics. Yes, they're introduced by pediatricians, but again, those are all topics that are relevant for adults and things that an adult hematologist would be most appropriate to get that type of care. The other thing as well, I will say, is in terms of the type of care, there are different models of care depending on where you get your care. Some places may have somebody who's trained in internal medicine, but is an adult doctor, but then has a specific interest in sickle cell. So they can function and they have learned all about the important aspects of care for sickle cell. Then you have another model where you have a hematologist that does sickle cell, other hematology problems, cancers, etc. And then you can have a different model, kind of similar to what I and some of my colleagues practice here at HUP is we only do non-cancer. So we don't treat any cancers. And I have a special interest in red cells, specifically sickle cell is one of them. And so we can create a comprehensive program where all we're thinking of is sickle cell and the sickle cell patient, working with nurses, social workers in a comprehensive model. So there's different aspects depending on where you are, but the key is having an adult hematologist who can really address the adult problems and not really focus on acute issues like, hey, I got pain, I'm going to go to an ED. That is one thing, but sickle cell is a chronic disorder. So even though someone may not have pain on a regular basis, that sickle cell blood is still floating around in different organs. And over time, affects the backs of the eyes. There's a risk of stroke. There's a risk of what we call pulmonary hypertension. It can affect the kidneys. And so the adult doctor is very important, and connecting with that doctor is really important because then there are guidelines. There are guidelines of what to monitor in an adult. How often should we be checking these different organs so that if we start seeing a problem, we can intervene with the different medications and treatment options we have to prevent those long-term complications. Unfortunately, what we're seeing, is when there isn't good adult care, patients just go to the ED when they have a pain crisis or they have a pain episode, but nobody's following them or nobody's screening or looking for those long-term complications. And so I think that is really, really crucial and a really big point to stress is the role of that adult hematologist is long-term screening and prevention. Yeah.
No, for sure. I mean, I think everything you said just rings so true, specifically the chronic versus acute, and what that care looks like. And the different complications that can arise and just ensuring that, like I go to an ophthalmologist twice a year to get the back of my eyes screened, making sure I don't have any types of complications, and other different specialty areas, which a hematologist may not be able to look at and diagnose, but they can ensure that you're getting those proper screenings so that you're able to have a longer and healthier life, right? So specifically talking about the acute pain and how that often drives those living with sickle cell disease into the emergency department.
Mm-hmm.
I just know personally that for myself and for so many of my other peers, we experience so many stigmas and disparities in specifically the emergency department because of the treatment that we get for our symptom and not for our disease, right? So when we have acute pain, we take opioids. Some of us take opioids, I should say, right? Because that was how sickle cell was initially treated. It was saying, oh, they're having pain, let's get them out of pain. But never really looking at the disease as a whole because there wasn't enough information on the disease as a whole. Now, times seem to be changing. There's definitely a brighter day on the horizon for treatment in terms of those living with sickle cell disease. However, historically, the treatment has been opioids. And because it's been opioids, we've been labeled as drug seekers, as those who are taking advantage of the system, those who are, maybe malingering in terms of faking our pain. Um, all of these things that I've experienced, not just as an adult, but also as a child too, right? So this is a label that's placed on us very early within the healthcare system. And what I'm so proud of Crescent Foundation, one of the things I'm proud of Crescent Foundation for a lot of things, but for one of the things that we do is we really try to educate and humanize the disease, in terms of going into different med schools and genetics courses and telling our stories, and hopefully providing an entry point to future medical leaders, and those who are going to be within this field of practicing medicine, to see what this disease is like up close and personal, and to hopefully encourage those to go into hematology. And if not even going into hematology, then we provided that access point to say, hey, I'm going to go work in an ED. Hopefully we've broken some of those stigmas, right? So when a sickle cell patient comes within their ED, they're not just seeing, oh, here's another sickle cell patient who is drug seeking, or I'm just going to give them, however much of this opioid, just to make sure that their pain is done. And I don't really care about any other symptoms that they may be displaying as well, right? So I was wondering if you could kind of shed light just a little bit about what we see or what you see in terms of HUP sickle cell program, and how sickle cell patients are treated in a program versus how they're treated maybe in the ED.
That's a loaded question.
It is. It's a lot of questions.
So, okay, let me see what I can do here. So I think if we break it down, um, so the landscape of, I'll take it a few steps back and kind of put things into context here, and hopefully answer the questions. So in terms of the landscape of adult sickle cell care in Philly, for example, great pediatric care. Unfortunately, once they leave their pediatric care, there's been limited access to adult providers. We estimate there are probably 1,000 or 1,500 adults living with sickle cell disease in the greater Philly area.
Wait, I'm sorry. I need to pause. I want to pause you right there. So 1,000 to 1,500.
We estimate it's really hard, but I think that's the estimate. That's a lot of individuals.
Yep.
And these are adults, and however, we've only had a few programs where only a fraction of those patients are actually getting comprehensive care. Most individuals access some sort of sickle cell care in those acute settings. So when they have pain and they access their care through the EDs. And so we at the Hospital of University of Pennsylvania, our program is relatively new. It's developed over the last 2 years, where through institutional support to improve care for adults with sickle cell, we have developed this comprehensive care model, which is led by myself, but there are also 2 other adult sickle cell doctors. We have 3 sickle cell nurses, 2 social workers, and we're hoping to get a psychologist as well, a pharmacist. So you can see there's a team that has been put together that's developed over the last 2 years, and our program has really grown, from 50 or so patients now to about close to a little bit more than 200 patients. So we've had a dramatic increase, and what we can say is what we offer is really that both acute management, which involves the ED, and then the chronic care for those complications. So a lot of collaborations with subspecialists, for example, your eye doctor, for example, or a liver or kidney specialist, but also assessing the psychosocial aspects of care for the patient. I think one of the biggest challenges, as you alluded to, is patients presenting in the ED, and that's a challenge really in many places, unfortunately. And we did a survey when we first were putting things together because we really wanted to get the patient input as well, and the ED providers. And we found that the patients were frustrated because they were stigmatized, they were not getting their pain meds on time, they were waiting out in the emergency room too long. The ED doctors were frustrated because they didn't know what pain medication or what dose to start a patient on, so they were frustrated because they didn't have any guidance. And then as hematologists, we were frustrated because there was no communication. So we didn't know when our patients were showing up in the ED. So we sort of started from the scratch, got everybody's input, and really developed a treatment algorithm. So anybody coming in with sickle cell pain, sure, this is, we focus on pain, sure, get them. We aim to, the most recent American Society of Hematology guidelines talk about when somebody comes into the ED, from the time they register to their first dose, we should all be aiming for about 60 minutes or so. And then they get frequent evaluations every 30 to 60 minutes to really get that pain under control. And so that's one of the key points that we put in our care pathway, sickle cell pathway at HUP. But then we also really focused on educating about all the different acute complications that a sickle cell patient might develop, from stroke to acute chest or something where an emergency doctor has to think about. So if there's something different, so going beyond that stigma of, oh, they just come in for pain, really the goal of educating med students, residents, nurses, physicians, everybody in the ED, that a patient with sickle cell doesn't only have pain, they can truly have bad stuff. And we need to monitor them we need to listen to them, we need to hear them, we need to hear what they have to say and act on it. And I think that once we implemented this plan, we did a sort of a 6 months and a 6 month post thing. We saw that, the time that it took to get the first dose went down from 110 minutes down to 90 minutes. We're still working on it. We're aiming for 60 minutes, still have a ways to go. But again, that communication has improved. I would like to report that there's been some changes with triaging in the ED. HUP is expanding the ED. So there's a new hospital building that's kind of popping up right next to us. And that ED is going to double the capacity of patients. So we're hoping that 90 minutes will actually decrease. So patients will hopefully be able to get their pain medications. We hope to develop pain plans. So that emergency room doctor doesn't have to, question the patient as to why they need what they need or why they're asking. I think one of the common things, and many sickle cell patients experience this, is they may actually need a higher dose, but the ED starts for a lower dose. So of course they're going to ask for more because they have pain, but that is assumed as being drug seeking, and it just starts down a very negative pathway for interactions, the whole ED interaction. And so by developing pain plans, the ED doctor doesn't have to think too hard. The patient can be reassured that when I go in, they know that this is what I need and this is what I'm going to get. And that hopefully will reduce some of that stigma. I think what we've really tried to do is educate. And I'm really glad to hear that Crescent is really involved in reaching out to genetics courses and med students, as you've just done, and continue to just show that actually most people living with sickle cell disease are just normal individuals like anybody else who want to live their life, want to contribute to society, want to have friends, relationships, have plans and goals, just like any other individual in life. And another point actually is we looked at our data, and it's very similar to um, what other centers show, is that most of the total number of patients that actually, so I give you our data. Of all the patients who present to the ED, 90% of them, of all the visits to the ED, 90% of those visits are by about 10% of the population. And so a very small percentage of patients actually go to the ED very often. Most people try to manage this on their own at home. Most people, when they develop a pain crisis or a pain episode, try and manage it at home because they want to continue to go to work or go to school or do their thing as best they can. And don't really want to be in the ED, don't really want to be in the hospital unless they absolutely have to. And I think that's the message to get across to a lot of providers, is that a person with sickle cell doesn't want to be in the hospital, just like anybody else. I wouldn't want to be in the hospital unless I absolutely felt that I needed to be there and somebody can believe me and help me and hopefully aim to get me out of the hospital so I can get back to doing what I want to do, right? So I think there's a lot. You know, you ask about the stigma. I think the opioid crisis led to some things. I think in our current times, I think there is very much so disparities and inequality and racism as well. You know, sickle cell does affect individuals of African ancestry. These are generally marginalized individuals, poverty, various psychosocial factors. And I do believe that addressing that is really important. Also in addressing the stigma. So we can educate about sickle cell disease and how it affects an individual. But I think they are systematic biases and inequalities, inequities that need to be addressed. At Penn, there's quite a lot of movement happening, and it's really nice to see because each division, department, emergency room, inpatient, surgery, whatever you mentioned, there's a mandate to really increase education about diversity, racism, inequality, and bringing that to the forefront. And I'm hoping that that will, in the end, continue to improve how we care for our patients. I hope that we, as a sickle cell program, are really trying to open the channels of communication between all the different providers in the hospital, wherever a sickle cell patient with sickle cell might go, so that we're here and we try to lead by example. We try our best to listen to our patients, and we have the best interests of our patients in mind. I think that's kind of what I would say, yeah, to address some of your initial questions.
Those are great. I think that just there are a lot of things kind of going through my mind. I was just thinking about the first time that you and I met, like face to face, right? And we had this meeting with all of these players in effort to try to really make a change within our community here in Philadelphia, on those who are impacted by sickle cell disease and our patients with sickle cell. And it was a meeting, so I dressed like it was a meeting, and I had on a shirt and tie and a blazer, and I remember you coming up to me after our meet, or like during our meeting, I think you said, you don't have to, be this formal. But I think that I appreciated the message and what you were trying to say is that, like, that's not who you were, as an individual, as a provider. But historically, I have had to present myself, in a manner that, didn't hurt my case,
Oh, yeah.
get some type of relief, to advocate for myself. But so that's something that kind of rang into my mind. And because of everything you just kind of pointed out, right? The disparities, the stigmas, the racism, and so many others, for me, a barrier for me, you're right. I don't go to the hospital for treatment. I self-treat at home, because it's dreadful to enter that emergency department and to, like, just have your heart in your stomach about whether or not the administrator at the front desk is going to believe you're in a crisis, and you can get back and get triaged as soon as possible, right? It starts from the very first second you walk through those doors, right? So I need to think about, all right, what am I going to wear? Like, I want to come to the hospital in something comfortable, which is sweatpants, a hoodie, my bag with all my essentials, but maybe I should put on something else, right? And unfortunately, it shouldn't have to be that way. Hopefully, it won't be that way in the future. But those are just things that I know that myself and so many others, just have at the forefront of our minds. I also wanted to say just about the pain plan, and I think that it's great that you all have a pain plan, and it's great that the ED is alerted of that pain plan. We just know that lines of communication can sometimes get fuzzy, and that's why we're here, and we appreciate you all doing what you can, to ensure that those pain plans are communicated. But sometimes, like you said, a patient can come in and say, hey, I need 8 of X, and the provider will say, well, actually, I'm going to give you 4, literally half of what the patient asked for. And naturally, it's not going to do anything because that patient, I have this saying where it's like, sickle cell is your job, but for me, it's my life, right? And we just want people to believe us, in terms of what our pain is, and that statistic of that 90% of those people, those living with sickle cell disease who enter the emergency department, only account for 90% or 10% of the population that you serve, is incredible. That's insane statistic to me, but that's just me. I like numbers. I like statistics. But yeah, I think that unless you have any other comments on that, I would like to. You answered like the tough questions, quote unquote. But I'm wondering. I just kind of named some of my challenges as someone who's living with sickle cell. What are some of your challenges as someone providing for sickle cell?
Oh, that's a hard one. Yeah, so I think there's several, and I can think of it, from a patient perspective, from a system perspective, and then even just personally. Um, I think from a patient perspective is building trust. I think for me as a physician, as a provider, and I think I speak for all the members of our team here, is really building that trust. And there is a history, sickle cell is, as you mentioned, it's your life. It's your whole life. It's affected you right from a very young age. Unfortunately, many patients with sickle cell have been in the medical system, um, and there are positive experiences and there are negative experiences, and you just don't know who this person who's sitting in front of you, what they're going to bring. And I think we see adults, and people have had many different providers in the past. And so building that trust takes time. and building that trust that um, we have the best interest um, in mind for the patient. There are some individuals who, yeah, there's, I think having the knowledge, having the science, having the guidelines of what needs to be done is good, is great. Um, but I think it's also, I always have to remind myself to be compassionate and caring um, to the patient. I'd like to think I'm compassionate and caring to begin with, but always needing to work on it. We always can improve. We always can be different, and every patient is different. Each individual, everybody's an individual, and we will respond differently. Um, and we get a whole range of personalities, and that's the amazing part of medicine is you get to meet different people, and they all come with something different, and you learn from your patients. And I think that building trust takes time. um, I think one of the other challenges from a patient perspective as well, when it comes is things may always have been done a certain way, um, and that may not be perhaps the best way based, evidence changes, data changes, what we know about sickle cell changes, and generally we're all human, and as humans we don't like change. And so walking a patient through that is is challenging, but is also rewarding, I will say. Um, I think from a system level, it's access to resources. I think that's been the biggest challenge since the first day I came. It's taken, for really putting our minds to this, getting getting divisional, getting institutional support. It's taken a good 4 or 5 years to keep pushing for it. And we still don't have all the resources we want. We have to start with the little bit that we get, show that we're making an impact in terms of care for patients, providing good care, and also, and then you ask for more, and then you get more, and then you do more and better. So it's trying to do the most we can with a little bit, but continuing to advocate for our patients and continuing to push for more access to resources for our patients. So I think that's one of the challenges as a provider. And then personally, um, I'm not Black. I don't know. I can't say I can experience. All I know is, yes, I have my experiences. Um, and I think I can, relate to some degree, but I can't relate fully. I don't have sickle cell. I'm not Black. I didn't grow up where each individual person grew up. I have my story. Everybody has their story. But what I do know is that I care, and I want to help, and I want to make a difference. And yeah, and I hope, and I always hope that that comes across. So yeah, those are some of my challenges. May
No,
not cover all of them, but I think, and then it's just staying positive. Sickle cell care. There are a lot of roadblocks along the way when we talk about whether it's access to resources, communities. There's societal issues that are beyond my control, or are, beyond my control. But I can do my small part, and I can feel confident that I'm doing my part. So yeah, I think those are some of the things that I kind of struggle with.
yeah, I think that just to touch, I'm going to touch on a few of the things that you said in terms of you just understanding, that, and recognizing the barrier and challenge it is for you not being Black within a disease that, like we said earlier, this is a global disease. It affects people of all different, backgrounds and ethnicities. But in here in the US, this is like a Black disease, right? It's a Black disease, and sometimes can affect brown people as well, um, but majority Black. And I think it's important for us as Crescent Foundation. One of our core values is community, right? And understanding what the sickle cell disease community is. And it's not just those who are living with this disease, you know, it's not just those who are caring for the disease or a caregiver for the disease. It's not just providers, you know, it's all of those who are impacted directly and indirectly. And I think that, you know, we have a job as individuals living with this disease to really be um, open and understanding to those who care, like you said, like yourself, you know, who care about this disease, but are not necessarily Black. Um, but understand that being Black is exhausting in itself. You know, you know, I won't go into all of that. So imagine being Black and then adding on a debilitating and devastating disease, you know, like sickle cell disease. So we need all of the allies that we can get. Um, we need to understand that a lot of people really want to help, you know, and those who are helpful, we will embrace them. When they aren't helping in ways that we feel necessary, we'll let them know. I'm thinking specifically just because I know that we've advocated quite fiercely, you know, for some of our population over at Hub, and we'll keep doing that, right? You know, like you said, access. Um, we want you guys need more, so we'll let you know. You know, like y'all want more, so do we. So I think that it's so important for us as a community to know that we're truly in this together. We are, and there historically hasn't been adequate care for this disease. Um, Hopefully, it's going to change. We have 2 new drugs for the first time in 20 years. There are more treatment options and curative therapies coming down the pipeline. It's a really, really exciting time for sickle cell disease. It's a really, really exciting time to be in this space, whether you're someone living with it, whether you're a provider, it's exciting. Uh, yeah, those are my final thoughts before we wrap it up. I'm wondering if you have any final thoughts as well.
Oh, I think I agree with you. I think this is an amazing time for sickle cell. You know, it's unfortunate that it's taken so long. The past is the past, but we got to look forward. We got to think forward. We got to think big. Um, People are listening, and this is our time. I think this is our time. You know, from the American Society of Hematology has made sickle cell one of their key points that they're going to work, and there's a lot of energy behind it, including advocacy both at the national level, locally. You know, whether it's helping with new drugs and getting those drugs or clinical trials to individuals, looking for more resources and um, expanding awareness. And I think that um, I'm just really, really excited about what you guys are doing. I think that, and some of it you've experienced too, is that as a provider, I can spend 3-4 years going to meeting after meeting after meeting and just being like, no, no, no. And it's like, please, we need more. And then you have a group of well-dressed, well-spoken individuals with sickle cell who very effectively get their message across to leadership. And I think that people listen to individuals who are living with the disease. I can advocate for you, but I think people need to hear your story as the individual living with it. And I commend you for creating Crescent and for all the amazing work you're doing. And I think that these are exciting times, and I strongly encourage you to keep at it and to continue to build that collaboration. And that's how we will be successful. And we count our successes little by little, and we rejoice with every single one.
Yeah.
And that's how it'll get. Yeah. So
No, for sure. No, we're definitely we're gonna tell our stories, but we're gonna tell, you know, all stories of those who are impacted by the disease, those who, may not be as well dressed or as well spoken, and still hope that they're believed, and we're excited to be able to be in a position to be able to effectively communicate what our plight has been. But like you said, this disease is so individualistic. We gotta blow this thing out the water, Dr. Sayani. We have to tell everybody's stories, how they're cared for, how they, met someone who had sickle cell because they came and worked for them in their restaurant. Just all of those entry points. It's just such an exciting time. And I'm really, really appreciative that we got to have this conversation. I'm looking forward to the work that, we'll do in the future in effort to really advocate on Crescent's behalf and also those living with sickle cell disease behalf. And thank you for everything. And I think that really wraps up our Founder Friday. Thank you all for tuning in. Be sure to follow us on social media. Facebook is Crescent Foundation and Sickle Cell Initiative. On Instagram, we're Crescent Foundation SCD. Any questions or inquiries, you can forward them to info@crescentfoundationscd.org. Again, Dr. Sayani, thank you.
thank you for having me. It was great. It was a great chat.